Welcome everyone. I'm Jasmine Arazi, Program Manager here at IPFCC. I am joined by my colleague Marie Abraham today, and providing expert technical support is our colleague Matt De Silva. Today's session is Better and Safer Together, Engaging Patients and Families and Improving Patient Safety. We are very excited to see how many of you all are here. Obviously, it's a topic of significant interest. Please feel free to chat in your name, organization, and where you are located as we're all coming in. We are recording this conversation so that we may share that with others who are registered for the recording and to post that on our website. While we like seeing faces, if you prefer, you may go off camera. Next slide. We want to take some time to acknowledge our PFCC Connect sponsors. Thank you so much to Emory Healthcare, Providence Healthcare, and University Health for your continued support. Thank you. Next slide. As you know, our conversations are intended to be interactive and informative. We will share a few slides to set the context and to provide information to get our conversation started, but then we will dive right into the discussion. We want to remind everyone of our group agreements here. That is to be as present as possible. When we move into our discussion, it would be great if you could go on video. Next, participate actively. We encourage you to be curious, to ask questions, but also share your experiences, your perspectives, and any challenges that you have faced. You can either do so in the chat, or you may raise your hand and wait to be called on. Let's share this space, allow others to contribute to the conversation. Embrace a learning and growth mindset. All of you bring expertise, and we have a lot to learn from each other. And finally, we hope that you enjoy the discussion and have fun. If at any moment you experience technical issues, you may chat directly with Matt De Silva. And now I will hand it over to Marie.
But thank you all to those who shared questions and comments when you registered. And we heard some of the issues that were very important to you and very interested in. And so there were 5 of them that I pulled out. And the first one was, how can we engage patients and families in improving patient safety in both direct care as well as in program and practice efforts? So that's a very general question, but I think that's the purpose of this Zoom call today. How can patients and families help in identifying medical errors and harms? Partner to improve patient safety, because this is something that can be tricky for staff and clinicians. How do we get leadership buy-in for engaging patients and families in patient safety? Yes, because sometimes it's a legal issue and they don't want to be kind of being transparent, but that's not the way it should work. And then finally, are there ways to measure the impact of patient and patient-family engagement, improving patient safety? I'm not sure we're going to have the time to get to that particular topic today, but I think it's important enough that we can kind of do that in a future conversation. So, okay, Matt, next slide, please. So why is it so important to ensure that patients and families are engaged in patient safety? If any of you were at the previous September informal conversation, you've probably seen that quote on the left-hand side. But we thought it was important to highlight it again because it does have a lot to do with patient safety. We should never restrict families and care partners from the bedside or even in a clinic practice, because they're essential to ensuring that errors and harms are not ignored or missed. And then on the right-hand side, This quote, healthcare is founded on relationships, and when we invest in relationships that foster respect, trust, collaboration, and open communication, we create a positive culture of safety. I think that building this culture is relevant to everyone, not, clinicians, staff, patients, family members. And this came from a discussion guide that was developed by Healthcare Excellence. And I'm not sure if we have people, Healthcare Excellence Canada, I should say. I don't know if we have people on the call here today, but it would be great to hear from them because they have excellent resources. Next slide. We brought this slide back also from the previous presentation, just to highlight the importance of family presence to patient safety. So there are errors or harms that could have been detected by or avoided if families and care partners were present. I think we learned a lot of that during COVID time. There could be delays in diagnosis. There could be patient falls. There could be clinical deterioration. And there can be confusion about the discharge information. For instance, do the patients leave knowing how to appropriately use their medications? Or do they know what symptoms to watch out for? If not, that can lead to readmissions to the hospital. Next slide. So this just came into the into my space, I guess. Why is patient and family involvement important? So CMS has released this new patient safety structural measure that will go into effect in 2025. And the purpose is to make sure that hospitals are implementing practices that address the harms and errors. We know that that's still happening in hospitals. It also will assess how well hospitals are implementing those strategies to improve patient safety. There are 5 domains, as you can see. And the 5th is the patient and family engagement, which I'm so happy to see that in this. So I think what they are looking for, and I'm going to read the quote from their measure. The effective and equitable engagement of patients, families, and caregivers is essential to safer, better care. Hospitals must embed patients, families, caregivers as co-producers of safety and health through meaningful involvement in safety activities, quality improvement, and oversight. So I'm just so happy to see this coming to light. Next slide. CMS stands for Centers for Medicare and Medicaid. Yep. So I've broken this into 2 categories. The first category is supporting safety at the direct care level. And then the second one is looking at it, supporting safety in program and practice improvement level. So I'm going to just start with direct care. So we have to make sure that we understand and acknowledge that families are not visitors. They're essential care partners who have critical knowledge of the patient. In order for patients to really understand why they are essential to supporting patient safety, they need to hear from staff and clinicians about why this is important. And it has to be in clear, understandable, and appropriate languages. So probably many of you know that we have disparities in patient safety outcomes. We have it in US. I'm going to assume we might have it in Canada. We might have it in many other countries. So we encourage you to use a health equity lens when you're interacting with patients and families. And in doing that, you can avoid bias, discrimination, and inequities. And I love this quote from, let me think. Oh, this is also from Healthcare Excellence Canada. Cultural safety is essential to patient safety. Rounds and change of shifts are obviously opportunities to get important information from patients and families. That's not the purpose of rounds and change of shift reports. The purpose is to make decisions, develop care plans, whatever. And the change of shift is so that, that one person hands off to another person and they know what happened to the patient in the shift before them. So asking patients and families for their observations and any concerns they have related to safety is critical to improving patient safety, and then actively listening to their perspectives and acting on them when you can. So I don't know how many of you have rapid response teams. I'm assuming most of you do, but one thing that patients and families, especially if they're first timers in the hospital, they might not know what rapid response teams are. So explain what they are and what the process of the rapid response teams is to the patients and families. Provide materials that educate them about when to and how to activate the rapid response teams. For example, you can use posters, you can use pamphlets, you can put short video clips on hospital channels or social media, however you get information to patients in the hospital. Next slide. Okay, so now we're doing the deeper dive into the uncomfortable part. Staff and clinicians may be very uncomfortable communicating to patients and families when an error, a serious adverse event, or a near miss occurs. However, this is really important to develop the trust and a trusting relationship with patients and families if it's delivered in a very timely manner. Staff and clinicians may also be very wary of sharing what happened. However, we know that being truthful and transparent in disclosure will help patients and families understand what happened and why did this event happen. We know that from several hospitals have found that honest and transparency can lead to less legal action. Everyone involved in an incident is affected by the harms and errors and can experience trauma. So it's critical to be sensitive and responsive to the emotional, psychological well-being of patient, family, staff, and clinicians. Everyone's been touched by this. Provide the patient and family with the supports they need and follow through. Do it for staff and clinicians as well. Everybody needs that support to help them get through this. So root cause analysis, which explores the reasons for the harm or error occurring, is important to those who were affected. Patients and families may or may not want to be involved in root cause analysis. It might be, traumatic. It might be a trigger for them. But you can provide options for how they can be included and let them decide, or how they can get the information from that root cause analysis. And when we move into discussion, I'd love to hear from people if you're doing this, because I know some do and some don't. Next slide. Okay, so supporting safety and practice, program and practice improvement. If your organization has a patient and family council, involve them in improving patient safety. That is a great resource. Here's a variety of strategies that you can implement. You can make a request to be invited to present at the PFAC about current patient safety initiatives. You can use that opportunity to ask the PFAC, are they interested in including patient safety in their agenda in the future? You can also ask if there are any PFAC members that have an interest in serving on a patient safety committee, a task force, a quality improvement initiative. And then prepare PFAC members to effectively participate in committees, task forces, QI initiatives, and prepare the staff and clinicians also to partner with PFAC members, because I think that's so essential. If your organization doesn't have a PFAC, but you have patient and family advisors or a partner program, work with the coordinator to recruit and invite those advisors or partners to be involved in patient safety committees and task forces and in the QI work or research, actually, if you're doing research around patient safety. Also prepare them to participate and prepare staff and clinicians for collaborating with patients and families and partners. Next slide. Okay, so there's some activities that can be implemented to support patient safety program and practice improvement. And I just pulled a few of these. You can see if there are PFAs that have had experience with patient safety issues. Ask them if they're interested in sharing their experience to help the healthcare team gain knowledge of how these events can be avoided in the future. You could convene a workshop to learn about patient safety experiences and integrate that information to brainstorm ideas for how best to improve patient safety. I'm going to just give this great example from, again, Healthcare Excellence. They have a activity card workshop where participants reflect and discuss ideas how to improve patient safety. And you can access this activity card and other resources on their website. So patient and family advisors who have experienced patient safety issues are great resources to involve in root cause analysis or incident analysis. So I think you can tap into their perspectives and learn a lot. And then I don't know if any of you have done experience-based code design. I have done it. It often takes a long time. In this approach, all perspectives are obtained and clinician staff, patients, and families are brought together at the end after they're individual or in small groups have worked together to share their knowledge and their ideas. If you're working on improving patient safety, you might want to implement this process. You don't have to follow this exact model. Actually, I think it's proprietary, but I just provided it as an example. Next slide. So in summary of all of what I just shared, this is a list of strategies from the World Health Organization Global Patient Safety Action Plan for 2021 to 2030. So I don't want to read them all. I'm just going to give comments about each of them. The first one, engaging patients and families in civil society and organization and co-development. Okay, perfect. Encouraging healthcare organizations to include the patient perspective in planning and design of health services and quality improvement is one way to ensure that there's safer care. Number 4, 2, learn from the experience of patients and families who are exposed to unsafe care. Yes, so some errors, adverse events, and near misses may be more visible from the patient and family perspective and might not be detected by other clinicians and staff. So it's important to listen to the voice of the family, patients and families. 4, 3, build the capacity of patient advocates and champions in patient safety. Engaging patients and families will help drive sustainable and effective improvements in patient safety policies and practices. So it's really, really important. 4, establish the principle and practices of openness and transparency. We talked about that. One strategy that we use here in the States is, and other countries do as well, like Netherlands, Sweden, but increase patient access to their medical records. So that can be through electronic health record portals, messaging platforms. Here in the US, and maybe in Canada is using it as well, I'm not sure. But Open Notes is great, and it's they explored a system to allow patients to view their and comment on physician documentation of encounters. So that way they could definitely identify, hey, did he get something wrong? Did she get something wrong? And then finally, provide information and education to patients and families for their involvement in their own care. Ensure that, make sure, because again, it's the health equity lens, ensure that vulnerable populations such as those with limited health literacy, language barriers, elderly, those facing challenges related to social determinants of health are not excluded. So again, written materials should be clear and in the form of pictures, images, videos should be considered actually. All right, so I'm going to close and start with our discussion. So let's open it up. You can raise your hand. You can put the chat in the chat. You can do whatever you want. I saw the chat blowing up. Yes, Raleen? You can unmute. You need to unmute.
I'm sorry, I seem to be an addict to this topic, but I had an incident with my husband in the hospital a couple of years ago that raised a real question for me, also based on some literature that I'd read. And I think of it as a patient safety issue, but also as a staff safety issue. And there's the background for what we call workplace violence. And I, after this incident, called it patient self-protection sometimes because they don't know what's going on. They don't understand. And staff say to me, we don't have time to stop and explain and get permission or consent and all of those issues around resources. And I'm very interested in, am I way out in left field on this issue because I see it as both patient safety and staff safety, and we need both. And we need kind of behaviors that result in both to improve safety and well-being. And I'm just interested in other people's perspective.
Yeah, I can just comment briefly on that a little bit. We did get 2 people who mentioned workplace violence and supporting staff. So we did get that, and I thought that's such a very specific topic that we should probably address that in another informal conversation because it's really important, and we've done presentations on that before. So thank you, Raylene. And I think you're
I have a
right.
quick-
Yeah, go ahead, Peggy.
Oh, sorry, I didn't
No,
mean to cut
go
you off.
ahead. Oh, I don't care.
So I was just going to say that I'd be happy to share. And I think we have a couple of our team members on. So I'm the Chief Patient Experience Officer at Nemours Children's Health, and we were thrilled to see this topic. And we actually have expanded upon the Joint Commission Speak Up initiative. And so they have materials, but they're primarily designed for adults. And so we've developed materials that are appropriate for pediatric settings that give families specific information relative to either the procedure, the floor, the diagnosis they have, in terms of what to look for, what can they do to partner with safety and enhance safety. And I've also started kind of a culture shift in terms of how are we training our clinicians and frontline staff to communicate that leave room for those questions and for speaking up about concerns and letting us know about something that may be indicative of a safety concern. So that's something that we've enjoyed rolling out the last, I guess, about 6 to 9 months or so.
And I see
Happy to share.
Yes, okay, perfect. Thank you. Rochelle?
Thank you. Morning, everyone, and thank you for hosting this. I have a couple of questions around involving patients and families in root cause analysis or critical incident reviews. One is, if anyone's done it, if you have any kind of insight on how you helped the culture shift, because it is a culture shift. There's quite a bit of change management to implement this and to make it sustainable. And then the second question I have is around any supports for these patients and families who are stepping up and agreeing to be involved in supporting these analyses. what are you offering them in terms of kind of emotional support, if they need counseling, and where is that funding coming from? Because there is potential to re-trigger, to cause additional harm. Yeah, I'm just interested on how anyone's approaching that. Thank you.
Yeah, thank you for bringing that back to the forefront, because I think it would be helpful. And Teresa, I see your hand up, and Marielle, I also see your hand up. So it would be great to hear from others who have implemented involving patients and families in the root cause analysis. So yes. Okay, Marielle. Oh no, Teresa first, sorry.
I don't have anything to share, unfortunately, about involving families in root cause analysis, but I did want to say um, we do include our families in our bedside shift nurse report, and we um, include our families in our family-centered rounds in the mornings. And we do that by sharing on our Get Well Network a message that tells the families what times the teams will be rounding with the patients. Um, and the bedside nurse is included to be able to share any concerns and advocate for the families. One thing of note is that our communication boards, while we are still paper inserts. Our Family Advisory Council has been heavily involved in continuously improving those communication boards. We have the phone number and teach the families how to be able to call a pediatric response team if necessary. We also have areas for the family that they can let the staff know whether they want to be awake or asleep for those 7 a.m. bedside shift reports. We also have information on there about what comforts the child and the pain levels. But then additionally, as far as safety, we have developed key cards that are patient and family facing that are about the size of a 5x7. Those are laminated and they are for a couple of our higher hospital acquired conditions such as falls, as well as our VTEs or blood clots. And it's written in a language that encourages families to be involved and partner with us to keep their child safe. So that's just some of the things that we have done here. But our patients and our families are continuously included in different pieces of the safety work.
Well, thank you. That's sounds amazing and great. So Marielle.
We have parents on every local improvement team, quality committee, and patient safety committee in the hospital. And so that group of parents meets monthly to kind of debrief and provide support for one another and share best practices. But then out of that came our parent participation in root cause analysis. We had the agreement and support from our chief quality and chief improvement officers for that to happen. And they developed, along with the patient safety people, an algorithm for when a parent would be involved in a root cause analysis, because it is, not everything is directly patient facing. And so they had an algorithm or parent facing. So I happened to be the parent that was involved in that. They wanted one of our parents who works in the office so that there'd be an opportunity to just make sure I was okay. And our director attended those with me so that we could debrief after, because as you're probably aware, you can't just talk to anybody about those kinds of things. So they were long meetings, but it was very well received. Unfortunately, that chief improvement officer left, and we've kind of lost a little ground as we've done that, but we're hoping to get back to having parents participate in that process again.
Thank you. Mariel, remind me of what.
Oh, sorry. It's
Okay.
Stanford Children's in California.
Stanford. You know Stanford very well. They do a great job in a lot of different areas.
Thank you.
Kelly.
Hi, yes. I am a volunteer patient and family advisor at the Medical University of South Carolina in Charleston. And I sit on all of our root cause analyses. I'm invited to all of them, and I participate even if the subject matter is not necessarily related to something that I can weigh in on. And I was invited by our director of risk, and was just going to say that I received training beforehand. I always have the opportunity to debrief with someone afterwards if it's too upsetting to me. But in most cases, what I'll just say is it's the experience of sitting on them over and over again, which make PFAs, I think, um, um, able to feel comfortable weighing in. It's almost every RCA now. I am comfortable to unmute myself and weigh in and talk about things specifically related to patients and families. So it's that experience and time and sitting on multiple ones that I think makes a difference.
Kelly, someone's asked in the chat, what kind of training did you get?
So I sat down with one of our risk coordinators prior to my first RCA, and she went through the process with me. And then after the first one, she was available to answer any questions that I had. And mostly it was sort of an on-the-job sitting in and kind of learning about the process. But I did sit down with a risk coordinator who sort of went through the process with me before starting.
Great. And when you're in these meetings, are the patient or family member who was witness to this, are they in the room too, or is it just?
They are not. It's the
Okay.
clinicians that were associated, and then a group of kind of what I would call standard folks, of which I am one, who legal but the patients and families that the event is about are not currently invited to attend.
Okay. Okay, Cheryl, do you want to speak about the paid parents on staff that participate in patient safety and quality in the RCAs?
Sure. So at Children's Mercy in Kansas City, there are two of us parents. We have been employed for 16 years, and we started participating in the RCAs probably 12 years ago. It was our executive vice president of quality that invited us to do it. I think the other members were comfortable with us being there because in addition to being parents whose children spent a lot of time there, we were employees. And so right now they are very comfortable with that. We have not moved beyond having the paid parents do it to volunteers doing it yet.
Great. Yeah. Okay, we have
Maria, it's Donna Provenzano.
Yeah. Oh, hello.
Children's Specialized. Hi, I'm sorry, I was having some trouble being able to raise my hand. I apologize. I just wanted to share at Children's Specialized Hospital, we're part of our larger health system, RWJBH Barnabas Health System. And, we have a high reliability focus in terms of our organization is promoting safety together. And we had our Family Advisory Council worked 2 years ago to revise materials around safety together. They were initially established for staff, but our family advisory took those acronyms of safety, speak up for safety, accurately communicate, focus on the task, exercise a questioning attitude, thoughtfully interact, and you and me together. And they put that into language that our families would understand for our inpatient population, our long-term care population, and outpatient. So just one example of how we've been partnering in safety together, in addition to having, families serve on all of our key patient safety and quality committees.
Thanks, Donna. You all do a great job there too. So, let me see. Oh, there was a wonderful chat about the Swiss cheese method of going through. And I'm wondering, let's see, I can't scroll back. Hold on. Some people might not know what that is. So Jennifer, are you available to come on and talk about the Swiss cheese model?
Yeah, so I think when we're talking with our patients and getting them prepped to be a part of root cause analysis, it's really important for us to understand the philosophy of why we're doing this. And so, we really discussed the just and trusting culture, that this isn't about finding somebody to blame. This is about learning to improve. And we talk about the Swiss cheese model of like errors happen because lots of things lined up in the right way to let something get through all the safety links, and how do we close those safety things. And so, it just kind of reinforces that piece of like, it may not be the obvious things that we're looking for, like we have all these safety things in, but how did everything line up to create this opportunity, and how could we close those holes a little bit better. So we do a number of things like that. We also do some system analysis training with our quality assurance patient family advisors. They get a quick crash course in like a better together or better in a healthcare improvement, kind of quality improvement, work process improvement, process analysis kind of thing. So we give them kind of a quick and dirty run through of all of those courses that we've always spent months and months taking, but to kind of bring them up and give them some of the same language that our staff have in going through these quality pieces, so that when they're hearing PDSA cycles, they know what that means, and when they're hearing about the Swiss cheese model, they know what that means, and things like that. So pretty robust. We really like our our quality assurance committee members to have previous patient advisory experience before coming into a quality council. And we're also very aware that that we're really trying to match if this is a safe situation for our patients. We don't want to increase or harm our patients anymore by putting them in a situation that might hit too close from home. So a lot of pre-briefing, this is the piece that we're going to talk about, and having that liaison that really knows that patient's background and experience. We're going to talk about a baby who died in childbirth due to a medical error. I know you had a loss of a child in hospital. Do you think this is something you can be a part of? How do you want to be a part of it? Do you want to pre-look at it and then on your own just give us pieces? Do you want to hear about it in the meeting, and kind of like really knowing and having that relational piece so that we can kind of fix and maneuver the way we engage them in a way that doesn't traumatize them more.
Thank you for sharing all of that. So Irene.
Yeah, I have to change my background for next time because I couldn't even see my hand up. Okay, so I'm come from Canada, probably the most under-resourced healthcare system currently in Ontario anyways. And one of the things I think we're going to have difficulty with is with this concept of patient engagement, is the fact that it's going to be, I think it's going to it might start out to feel like an additional responsibility on an already overloaded system. The thing is that what is really critical, I think, is the relationships we have with each other on the healthcare team. And relationships take time because you have to develop trust. And I think that is a challenge these days when everything has become, from in my experience, very transactional. We're doing a lot of things to patients and not so much being with patients. So to come along and say, okay, now we're going to ask you to include the patient in every step of the way, or let's say small time, we'll start with something small. I can see that there may be a lot of pushback with that. And I really like the idea that Teresa was talking about, is like almost hardwiring it so that there are these boards and these rounds. And so it becomes just part of the way we do things around here. Because I think that a lot of people don't get that patients are really an asset to their healthcare in terms of allowing them to get better. They're a huge asset. In fact, there's someone in Alberta who came up with like a PAM measure. That's a patient activation measure. And she showed that the more involved the patient is in their care, the better their outcome will be. And I think bringing information like that forward can encourage people to get on board and kind of walk the talk, because it's really hard times. Everybody's overloaded. There's moral distress. And I think our healthcare workers need as much support as possible. So, and we need to try to couch it so they can see their patients as their allies, because really the patient is the only constant in the system. And context is about everything in healthcare, because everybody's journey is unique. So it really allows us to make the right decisions together.
Yeah. And Irene, you shared your whiteboard.
Oh, yes.
Yes.
Right.
And can you just talk a little bit about how that whiteboard comes into play in patient safety?
So there's whiteboards at the end of the bed of each patient in our hospital. And as a volunteer, I come into the room and introduce myself to the patient. It makes it easy because their first name is on the board. So number one, that's great. And then I ask the patient, is everything on the board here, which kind of dictates how they ambulate, if they have any limitations with communication, planning for discharge, goals for the day. It's just a board that writes that all out. Who are the staff caring for them that day? So I thought it was really, really great when I came on board, except I noticed a lot of times it wasn't being updated. So I started to make that my job. But at the very bottom is the most important part. It says questions for my team. And that's for the patients to figure out. But it was always empty. So I would come up to and say how you have a lot of people looking after you. I bet sometimes it's hard to know who to ask what. And I would encourage them and say, you can write something here, and then lots of people will read it, and then we'll get around to the right person sooner than if you're trying to guess how to get it across. So I started to help people with the whiteboard. And I just have a really short story. I came in and saw a patient. He was there with paraplegia, which means he couldn't get up to write. And I said to him, can I help you with anything today? He said, 3 things. My glasses are broken. The lens is popped out of them, so I can't even see that board. Number 2 is that they're giving me a soft diet, and I always eat a regular diet, and I hate this soft, mushy stuff. And number 3 is that I have this sore on my head that's been bleeding and really bothering me. It's been there for months, and I'm waiting for an appointment. Do you think someone here could see me? And so I wrote those 3 things down. And how you write them down obviously matters. And then by the end of the shift, I came back to see him, and all 3 things had been done. It was like a miracle. And he was so grateful. So it's just an example of how those little bits of care really were so important to that patient. And I really felt happy that I could enable that. And that was because of the whiteboard that gave me the chance to help the patient say what's important to them.
Yeah, thank you, Irene.
Well,
It's wonderful. Okay. Kelly, did you have another question? Because your hand is still up. Or comment.
Sorry, I just forgot to drop it.
Oh, that's okay. Teresa, you just put in a great chat. So do you want to talk a little bit about that as well?
Sure. So my position being the paid parent, family partnership coordinator, I'm in a very unique position because a lot of people in my role don't get the opportunity to be called in to conduct rounds with families and on the units. And so we call what I do, the majority of them are called comfort rounds. And those comfort rounds, we know that most of the time families are going to share with me, a parent, more than what they would with staff. We find out more for whatever reason. But when I go in, I talk to them, start off, making sure that they know about the different ways we have to care for them, for the parents. And then I do kind of an environmental scan to look for the room. I look at the communication boards to make sure that they are completely and filled out and up to date. And also, I talk to them to make sure that there's good communication between all members of the care team and that they understand the plan of care and what the goal is that their child needs to meet to go home. And then we also check with them about, because we know that, pain is typically one of our biggest pain points for the hospital, no pun intended, right? But ask if we're controlling the child's pain. And then at that point, I typically find out different things like mom didn't have a charging cable. Mom wasn't aware that why is this, why is my child marked as a fall risk? Because, it's typically, it's not top of everybody's mind. Once it's put up, one and done. But we know 7 times, 7 ways. So I put this information either through a Microsoft form that I've created so I can track and trend, or I put the information we use Huron as our rounding tool, put that in there, and then I send weekly summaries, high level, just kind of calling out the pain points to the unit leadership so that they're aware, and they can focus. And they're, I'm not looked at as, the adversary when I'm going into these units. The people and staff look at me as somebody who's trusted, that's not there to make their jobs worse, not there to find problems, but I'm able to identify things in the moment that maybe they've not heard about and bring it and elevate it where it needs to go. And it helps them, but it also ensures that our families understand that they are able to take part in their child's care and be advocates.
Yeah, that's partnership there, Teresa. Seeing you as who you are and your skill set that you bring. So thank you. Oh, some people just said they have dug out early. That's fine, Rochelle. So I'm interested in hearing, because we haven't really got to this topic yet about, and I think Teresa, you hit on it with a little bit with the fact that you do a summary and feed that up to the leadership in the unit. But I'm wondering how people, or if you have challenges or successes with getting the executive suite, the C-suite, involved or at least supportive of engaging patients and families in patient safety.
I will say, just for us, and I don't want to take up the time, but our senior leadership, it has to come from the top down. And they are very heavily engaged and supportive of the work that we're doing.
Thank you. Anybody else? It's a tough challenge, I think.
Maria, it's Donna Provenzano. I mean, our senior leadership team, I mean, they're all in. They've, been committed to involving patients and families in every aspect of our organization. It's like the lens of how we do our work. So we're in a really fortunate place that our leadership team embraces families in everything that we do.
That's terrific.
And just to piggyback on what Donna said, because I'm so fortunate to work with her as a family, like that was the beginning of my journey so many years ago, because my daughter was diagnosed with severe cerebral palsy, and I've been part of Children's as a hired paid family member for almost 16 years now. And I could tell you, just from the family perspective, like I want to partner with the staff here because of everything I know that they've helped my own personal family with. And so, we want to give back to the hospitals that care for our loved ones, right? Like we're motivated to help make things better, not only for ourselves, but for the hospital and for other parents and patients that are coming along. And so when you recognize that families are motivated in that way to make things better, you'll find out that we're not looking to have retribution when we see errors. I mean, when you have a child like my daughter, who's in and out of the hospital, I've encountered many, many, many errors that have occurred. And then I also can appreciate how hard working the staff are and how stressed they are trying to maintain like amazing care for all of their patients. And so when when she had like her IV infiltrated, and like she was a child that never normally cried, but I could share with the nurse, like, no, she's crying, she's in pain, this isn't normal, something's wrong, something's going on. And when she listened to me, we could address the problem together. So we can help make hospitals safer environments, because we learn through our experiences that we can partner together to make things better, and we're not looking to do anything but help our children, help our families. And then the benefit is that it helps the hospitals reduce safety and harm, or
Mhm.
increase safety, reduce harm.
Thank you, Linda. I posted the whiteboard that Irene was talking about in chat. It's small, so you might not be able to see it. But we also, just let me make sure. Irene, is it okay if we send that to people? Oh, she's still on. You're on mute.
Yes, I took a picture so you could see it in real time, but then I also sent a file, so I don't know which one you mean, that made it more legible. It was the same, but made it more legible. I don't know if you got both of them. Mhm.
Okay, thank you. And we have 2 hands up, and so we will get to those, and then I guess we're gonna have to close. This always is too short. Anjali?
Hello, everyone. I'll try to be really quick. I would say yes to the support from senior leadership. That being said, in rolling out different quality and patient safety type of efforts, I noticed there is some, not reservation, but just staff wanting to be sure that like for example, we were having a parent advisor join unit councils, like we have unit-based meetings, and they're primarily quality patient safety focused. So I think the key, and I don't know if URMC is here, but so we plug into the SPS collaborative, and they had shared a really great tip of, someone said it here, training and prep. It really is important. So we stole from them shamelessly, and they basically, like, they had a pre-meeting with the medical director, the heads of that meeting. We set that up ahead of time with that parent. We chatted on Zoom, let them know what it's going to look like, taste like, everything, and get them and they got to ask them questions. So it wasn't just throwing them into the meeting. We only trialed that a little bit, but I do know that other units, there's some that are interested and some that are like, yes, but okay, tell me more. So I think that's where it is important to make sure that the staff are also, so yes, parents should be trained, but I think the staff should be trained too on how to
Yes, definitely.
work together. Yeah.
Yeah, thank you. Caroline, you're gonna finish up the discussion.
Hey, Marie, thanks. I'll go really fast. And just to say that, so I'm the program director for patient and family center care at MUSC here in Charleston, South Carolina. My work with the hospital started as a patient and family advisor, following my experience. But what I've learned over the years, that this is, we talk about building relationships, but we could probably do an entire webinar on building relationships, because it is the foundation of everything I've been able to accomplish, whether it be with our wonderful volunteer patient and family advisors, but also with leadership. So you hardwire this stuff, or you think you hardwire it because you've created a strategic plan at the system level, but leadership changes. And for those of us who've been doing this long enough, you know that. And so then you sort of have to start all over. And what does that look like? How do you build those relationships and then hardwire again all the things that you've been working on over the last decade? So I think, asking for time with leaders, being able to land the plane very quickly with people who are very busy, and asking them to join, and talking about the Patient and Family Advisory Council, and then telling stories and finding ways to tell those stories across your health system, in very succinct ways that are powerful, but again, that land the plane very quickly. So just a few tidbits.
Great, thank you, Caroline. It's good to see you here too. Okay, Matt, could you pull up the slides? I referenced several different resources during the call, and so I'm not going to go through them because we're running out of time. But the slides you'll be getting a copy of anyway. If you haven't gotten them already, they'll be posted on the PFCC Connect website. Next slide, please. Yeah, so there's 8 of them that I referred to in this conversation, but in addition, next slide, please. There's some organizational websites that are really, I mean, their focus is on patient safety. So these are the great and good. Thank you, Jasmine, for putting that in the chat. But again, you'll be getting this information. So SIDM, the Society to Improve Diagnosis in Medicine, they actually closed in August of this year. However, as far as I know, their resources are still currently available online. So if you are interested, you should probably try to access that as soon as possible. Okay, I'm going to hand it over to Jasmine to close us out.
Excellent. Thank you, Marie. Many of you are members of our free online learning community.
Next slide.
Next slide, Matt. That's PFCC Connect. If you are not a member yet, we really encourage you to register so you can access the great information and resources about patient and family-centered care. You can post questions there, learn from others, and share great ideas and resources, and really continue these conversations there. Next slide. We ask that you complete the survey as we really use these results to give us ideas to improve these conversations and to identify future topics. You can use the link or the QR code here to access that, and that has been posted on the chat, and the link will also be shared with you in the follow-up email. Thank you. Next slide. Our next informal conversation is scheduled for February 2025. The date and the topic is to be determined. We would love some input from you about any potential topics. And the recording, slides, and the chat log for today will be posted on PFCC Connect by early next week. You can email Marie Abraham directly with any tools, any resources, or links to relevant sites. And you can always continue this discussion in PFCC Connect. Thank you, everyone. This has been great, and we wish you a wonderful rest of your day.